My name is Devon Evans. I'm a physician with New England Cancer Specialists in Portland, Maine, specializing in the management of lung cancer. Biopsies with insufficient tissue for analysis are a common testing issue in clinical practice. When a quantity not sufficient, or QNS result, comes back from tissue molecular analysis, approximately 1/3 of the time it could mean missing a patient who should be getting a targeted therapy. Here are ways your practice can help to minimize the likelihood of QNS. Rapid on-site evaluation, or ROSE, can help with ensuring that tissue samples are adequate. ROSE can also help to triage tissue to prioritize analysis of mutations such as EGFR, ALK, BRAF V600E, and ROS1. In my practice, I would say QNS happens about 15 to 30% of the time. Our team has integrated ROSE into our practice to ensure optimal tissue quality and quantity. But even if your practice doesn't have access to ROSE, it's still possible to detect more mutations by integrating first-line plasma into your testing process. In one study, concurrent testing of tissue and plasma increased detection of actionable mutations by 17% over tissue testing. Also, 1 in 5 patients who were unable to have a tissue biopsy were mutation positive by plasma testing. An additional study showed that sequential plasma testing of patients who were negative by tissue biopsy or had a QNS result increased the rate of actionable mutations detected by 21.7%. It's also critical to have good communication with other members of the multidisciplinary team with a continuous flow of information in both directions. In particular, tissue conservation, maximizing tissue designated for molecular testing, selecting specimens with optimal tumor cellularity, and determining if plasma should be tested concurrently are important topics to discuss with your pathologist. Direct and timely feedback in these areas can lead to continuous process improvement. This process helps ensure that I can give my patient the best possible therapy for their disease. In my practice, I'm in constant communication with my pathologist. My multidisciplinary team will let me know right away if there is enough tissue to test for mutations, and if there isn't, I request a plasma test. Patients who have actionable mutations deserve therapy that's matched to the driver of their disease. Don't let QNS get in the way of finding these patients and treating them accordingly. Make sure to test your patients for actionable mutations, know their full results, and then treat patients who have actionable mutations with a therapy matched to their mutation.